In this session of the gluteal region, part 2 of the hip joint will be covered. This will include some functional aspects as well as neurovascular supply.
Hello, my name is Richard Fernandez. I'm one of the anatomy lecturers out at Bundura teaching anatomy.
Stability at the hip joint mainly depends on two factors: congruency and strong ligamentous support. Congruency refers to how well the two articulating surfaces fit together and the amount of contact between the two articulating surfaces. Any joint needs ligaments to support them, more so if they are weight-bearing. The hip, being a very strong weight-bearing joint, requires large ligaments to support it, and by now you should be familiar with the three main ligaments. These two factors work together to try and offer a greater amount of stability at the hip. The close packed position of a joint is also described as the most stable position of a joint. In this position, the bones are at their most congruent and all the principal ligaments are under maximum tension. It's very important to note that this is not the case at the hip. There are different positions for congruency and the close packed position. The close packed position of the hip joint is an extension and medial rotation. This is so because the stabilizing ligaments come under maximum tension.
So in this demonstration, I'll show you how the iliofemoral ligament depicted by blue tack should tighten up during extension and medial rotation. So here is the extension component and medial rotation, the close packed position of the hip. Now these ligaments tighten up due to the spiral arrangement of the fibers within the ligament. In this posterior view, you can see the ischiofemoral ligament, and it's the one that tightens up during medial rotation. You can see the fibers stretching there. So there's the close packed position with the ischiofemoral ligament tightening up.
The most congruent position of the hip joint is when it's flexed, abducted, and laterally rotated, sort of like sitting on a horse. In this position, the head of the femur and the lunate surface of the acetabulum have greatest contact.
So now I'm going to demonstrate the position of maximum congruency at the hip joint, which is flexion, abduction, and a little bit of lateral rotation. So here's that movement again from a lateral view: flexion and abduction, and a little bit of lateral rotation.
It's also interesting to note that the least stable position of the hip joint is when it's flexed, adducted, and a little bit laterally rotated, sort of like sitting cross-legged. It's in this position that the hip can be easily dislocated if external forces are applied. Now I want to do a quick overview of the muscles around the hip that would move the hip joint. First of all, the flexor is located anteriorly, and that is the iliopsoas muscle, which you can see here. You can see psoas major and iliacus blending in front of the hip joint, forming iliopsoas. Posteriorly, of course, there's gluteus maximus. Medially are the adductor grouped muscles, which you'll see in the session on the thigh. And posterolaterally, technically a little bit superiorly, we have the abductors, the gluteus medius and minimus muscles. Here is a diagram that depicts muscle location and action. Here on the schematic, you can see the flexors are anterior in purple. There is iliopsoas muscle. Here you can see the abductors, gluteus medius and deep psoas minimus. Now, although their muscle belly sits superior to the joint, it's very important to note that their tendon crosses the joint laterally, and that's what makes them abductors. The fact that their tendon also crosses obliquely allows them to act as rotators. Posteriorly, you can see the extensors, gluteus maximus, and there it is. We also include the hamstrings as extensors, but they will be covered in a session on the thigh. And medially, we can see the adductor muscle group, located inferior to the hip joint in this diagram, but they're also medial. Now you should stop and complete the activity associated with hip joint movements and muscles. The neurovascular supply of the hip joint is rather extensive. First of all, it's important to know that the nerve supply of the hip joint covers everything except the articular cartilage. So there would be somatic afferent fibers that would supply the capsule with proprioception, the bone with afferent neurons, and of course the ligaments with afferent neurons as well. Visceral efferents supply the blood vessels. Now the most predominant nerves supplying the hip joint are the femoral, obturator, and superior gluteal. Try and apply Hilton's law here and appreciate how the nerve supplying the joint will also supply the muscle crossing it. Now here's another activity I'd like you to try. I'd like you to apply Hilton's law to the region of the hip joint. Based on the anterior, medial or posterior parts, indicate the nerves supplied and also list any additional structures that nerve would go on to supply. You can fill out this table and you can also post your results on LMS. The major blood supply of the hip joint comes from the medial and lateral circumflex arteries, which are a branch from the profunda femoris artery. There is also a little branch in ligamentum teres, which comes from the obturator. So let's have a look at these in a diagram. Here we can see the abdominal aorta descend and bifurcate into common iliac arteries. You can also notice the common iliac artery descend, give off a branch, internal iliac, and continue as the external iliac. As soon as the external iliac crosses under the inguinal ligament, it's now referred to as femoral. The femoral will continue into the thigh, where it will give off a branch that's deep. To be deep means to be profound, so this artery here is named the profunda femoris, the deep branch of the femoral. It is from the profunda femoris that the lateral and medial circumflex arteries branch off. So here's a zoomed in view, and you can quite clearly see the lateral circumflex artery and the medial circumflex artery. The most important concept with these two arteries is that they join, they anastomose, and when they anastomose, they allow a continuous collateral circulation. So if one of these arteries is compressed or kinked in a particular position that the hip is in, blood can take an alternate route to supply the hip joint. You can see distal to the anastomosis, there are many arteries that are perforating through the femoral neck. They will not only supply the femoral head and neck, but they will also supply the trochanters. Here you can see the tip of the femoral head receiving a little arterial supply through ligamentum teres. That, of course, is coming from the obturator artery, you can see here. So I thought I'd do a very quick summary of all the structures we've covered in this session on the hip joint. First of all, on this coronal section, you can see part of the acetabulum and ilium, the head, neck, and shaft of the femur, along with greater and lesser trochanters. The same applies for the schematic. What you'll notice here is the synovial membrane and joint cavity. It's the same thing here. The synovial membrane is depicted as the dotted line. Notice it's attaching to the articular margins of the hip. It's not lining the hyaline cartilage on the articular surface. The next thing is the lunate surface. It's the only articular surface of the hip bone. Over here we can see the hyaline cartilage lining the femoral head. Here we can see ligamentum teres on both diagrams, inserting into the fovea capitis, and the joint capsule. Here, superiorly, you should see the joint capsule thickening part of the iliofemoral ligament. Over here will be a combination of pubofemoral and ischiofemoral, depending on how the coronal section has been taken. Now we can see the acetabular labrum. Remember, this structure deepens the articulation of the hip joint. It's only seen in this schematic. You can't see it on this one here. And finally, we can actually see the fat pad that sits on the acetabular fossa, that rough and non-articular acetabular fossa. Notice also there's synovial membrane that lines that fat pad. This concludes part 2 of the hip joint from the session on the gluteal region.